Please welcome to the stage Abigail Norville and Steve Posnack.
No. I like the enthusiasm. End of the day.
Really?
All right. Thanks for joining us. I know that you had your choice of plenary sessions, so we're glad that you chose ours. I was already introduced by the voice above, but again, for those of you, Steve Posnack from ONC, serves as our Deputy National Coordinator for Health IT. We came up with the longest possible title for this session. I think we could have suggested just 2 deputies.
Could have.
Because that is what we are. And you know, one of the things that I think you heard this morning, a lot of our domestic efforts within the U.S., and I'm sure you've seen a lot across the different work sessions that you've been able to go to today. I recognize that today is also, this session is also at the end of the day, and so we have a lot of energy that we've already expended, interpersonal contact that we may not be as used to. For those of you that are wired as introverts like me, I will go sharply into my fortress of solitude later to recharge. But for the session today, what we wanted to give you is a bit of an experience and understanding of some of the work that ONC does at a global level, which you may not necessarily be familiar with, and introduce you to one of our key partners from the Netherlands, in addition to the kind of formal handoff of a period of time and a role that I've had the great fortune of serving in for the past 2 years. And that probably is a good segue. We are part of a group that I like to call the Government Geek Squad, and the formal name is called the Global Digital Health Partnership. So this was created in 2018. There are now over 30 member government countries that are part of the Global Digital Health Partnership, GDHP, so it rolls off the tip of the tongue. You know, we are the peer equivalents to each other in the departments of health or the ministries of health that lead digital health for the various government entities. And so, you know, we may be part of a Ministry of Health, maybe part of a Ministry of Finance, or other types of constructions that exist within the different governments, but we all share a similar passion. And it's really interesting to get together with our peers across government, because the health systems that we work in, the governments that we work in, operate differently, but the challenges that we face and the solutions that we're trying to build and the work that we do with our communities is often pretty similar. And so you find that we're each working on strategic plans, or patient engagement related activities, or other types of communications where I love learning different idioms across the different countries, as my colleagues understand, and you know, sharing those types of experience, you know, across the different government leaders when it comes to the work that we do. And so while payment may be different, the work that we are trying to accomplish from a digital health perspective is often a kind of shared sense of appreciation.
This was actually my whole story, you know that.
I'm sorry.
Okay.
Abigail and I have known each other now for 2 years, and we didn't practice the whole comedic routine, but we are here for the next 40 minutes, so you're stuck with us. You know, so just to give you a sense, again, domestically for ONC's related portfolio, you know, we participate in GDHP. I've been the chair. We have 5 work streams that us government leaders decide to work on and get together. That includes interoperability, no-brainer, cybersecurity, clinical and consumer engagement, although I think it's been changed to human engagement. I should get the new name right. Policy environments, and evidence and evaluation. Got them all 5. All right, I didn't choke on stage. So, you know, we gather together roughly twice a year in person now at this stage 2 to share those experiences and update each other on what's going on domestically as well as internationally. And that's also, I would say, converged into highlighting the fact that digital health is now a main policy level topic at G7, G20, WHO. the ways in which governments are improving the care, achieving universal health coverage, delivering other types of services if they have national health systems, is through digital health. And so we have lots of opportunity to collaborate internationally as well. Humble brag here, as you saw this morning, we're making a lot of progress in the United States. In some areas, in some use cases, we're ahead of our international peers. Had lots of engagement related to the certification program for health IT, which many are looking to replicate in some form or fashion. And so we were able to provide and export advice to our colleagues to help them, in some cases, leapfrog where we are, and in other cases, rapidly get up to the same place where we are as well from a domestic perspective. And so lots to share, and also to recognize across these international cooperative activities among governments that digital health is really having a big impact in terms of the milestones that they're seeking to achieve. Brazil has now taken over the presidency for G20, and they're carrying forward this year a digital health priority that our colleagues in India started last year as part of G20. And so it's just good context to keep in mind, despite all of the work that you feel like we've released upon you, this week. There's lots going on if we pick our heads up and look internationally across our borders as well. Really good relationships with our colleagues in Canada. Lots of opportunity there in terms of cross-border exchange too. So with that, done a brief introduction of GDHP. As I mentioned, I've served as the chair for 2022 and 2023. So in a mere few weeks, I will be relinquishing my chairmanship, transitioning to the Netherlands, who has served as our vice chair for nearly the past 2 years as well. Our colleagues from Portugal will be taking over as the vice chair for the next 2 years, and then subsequently, if they're able to, serve in that chair role. So we have a plan ahead and opportunities for engagement in general. We're continuing our recruitment across the digital health components in the governments that are out there, and I will now introduce my other deputy here, who serves as the Deputy Secretary General of the Netherlands Ministry of Health, Welfare, and Sport. Abigail is responsible for legal affairs and legislation and digital health across the Netherlands and the islands. So we thank you for making the trip.
You're always welcome.
It's the second time in this year since we had a summit in DC. And I'll start off with kind of the first question. Just for everybody's expectations, we're going to go about another 30 minutes or so, and then we'll open it up so you can ask some questions. We've had other international visitors here at our annual meetings in the past, and have always found the opportunity to engage and have some kind of cross comparisons and experiences has really been the most beneficial part as well. So our audience is interested,
I hope so,
in learning more about the Netherlands. I always wonder with like the panel setups, just like you saw this morning, we wind up always talking to you as the audience, but it's supposed to be a fireside chat where you're kind of just watching us talk to each other. Okay. So I'll try to face you a little bit more.
Okay, we're gonna ignore them?
Maybe, you can, don't ignore them so much.
Okay.
But, all right. So our audience is interested in learning about the Netherlands' work to advance digital health. And if you could give us a sense of kind of the policy environment, the data standards work, similar responsibilities that we have, yep, and kind of where your efforts are going at this stage today. And I think in particular, one of the patient engagement activities is the MedMy yep, activities as well. So that would yep, be great to cover.
Yeah. First of all, thanks for having me. It's always nice to be here and always nice to have such a large group of people who are interested in the subject. I think it's important. About the Netherlands, as you maybe all know, it's a small country, not as big as the United States of America, but it doesn't mean we have different challenges. We have the same challenges to our healthcare system with aging population, rising costs, and not enough people to work in healthcare. And that's just fact, and that we need to address, and we are addressing. So we have to change the way we deliver healthcare. We cannot keep doing it the same as we did. Well, the Netherlands, as you may know, is below sea level. That has nothing to do with healthcare, but it has got everything to do with how we operate in the Netherlands. We have this way of working we call, it's a Dutch word, polderen. It doesn't have an English translation, but it is meant that you put everybody who is involved in the problem and also in the solution together in one room. Maybe it's a bit comparable to the one system in the room approach. And you talk and talk and talk things through until you have a solution that everybody can say yes to. And that is how we arrange to have an agreement, accord.
We call those escape rooms here.
The what? The escape rooms?
Escape rooms, it's like to go through the strategy and the.
I don't know if it's the same because people are laughing. I don't know. But we have an integral healthcare agreement. And it's with the most important healthcare providers, but also the people who pay for it, like the assurance people. So it's a whole broad group of people, and they all signed to agree that things need to change. I think it's really positive that we have this agreement, but now we are taking it also to the next step because it was an agreement on, how do you say that, headlines, like this is how the future is going to look. But now we are talking about another agreement that says how we're going to do it. So not only what, but also the how. So, and I think that is a good thing because it's practical, and if everybody says yes to it, you can also hold people to the agreement. We also published our national vision and strategy on the health information system, which was also a really big thing because a few years back in the Netherlands, the politicians were very hesitant to make agreements about data sharing, and it was a whole thing, and it got voted away. So that set us back for a long time, and I think now is the time again that there is a moment to take things further because the urgency is there. What we also did is building trust models where government has a central role leading and directing. I think that also happened because the field asked us to give them some direction and also to tell them sometimes what to do. In practice, it's not always the same, of course. But then I also say, okay, but you wanted us to lead, we are leading now. So that gives a whole different conversation. But we created also a national trust framework that's called MEDMI. And this is very much like your TEFCA, but then for personal health data. So that's a different. And only service providers who are certified to the rules and standards can access the patient's data. And we use, and now I have to look at it, FHIR, yes?
Yes, FIRE.
All right. To unlock this data, and MedMy services are safe and secure. So that's a little bit in how it goes in the Netherlands. And you, Steve, because you had the chair for 2 years.
Yes.
You can call me for aftercare if you want, if you have like problems, you know. But how have you seen the GDHP helping member countries to develop and implement digital health programs and policies?
Yeah, absolutely. You can tell that our staff scripted this whole thing for us, and at some point Abigail and I will go off script, which is probably soon enough, although we probably already have at this stage.
I went off script already.
I know.
Yes. That's the difference between you and me.
So, the interesting thing, and I think the most rewarding experience aspects that I've had with GDHP, and I came into the group after it had been formed. For those of you that know what it's like to join in a leadership position at that stage, and just as you mentioned, some of the progress that the Netherlands has made. In many of the countries, we see new authorizing legislation, some of which may be a decade later than where we were from a High-Tech Act perspective, which is our kind of from 2009, real kind of critical piece of legislation for us. Others are further ahead in specific use cases, so they may have a better handle on how they do their public health data collection and population analysis. Still others are looking at now standing up electronic prescribing services. And so, what we find is that there's this interesting spectrum along the journey for each of the different countries, each of the different governments that have prioritized different types of citizen services and other types of health-related delivery changes that each start to build upon each other. And so it's really the value of both the friendship and opportunity to share experiences across the different governments about what works, what didn't work, What we would do differently, which I think, for those of you that worked on projects and been able to give that, those lessons learned to your colleagues, things that we wouldn't repeat again have really helped our other government digital health leaders go back to their respective governments and come back with real tangible and concrete examples or suggestions to how to push policy and strategy forward.
Nice. Yep.
So, we've learned a little bit about the Netherlands and the work that you all do from a digital health perspective. In terms of where you think you're going to take GDHP at this stage, could you give maybe us a sense?
Yeah. Well, I really like the fact that the GDHP is a group of like-minded people. So we are always looking for extra like-minded people and countries to join, because it's very rare that you can talk about these topics with people who do not have like a commercial, commercial goal to do this. And yeah, we have to take it to the next level. So that's where I want the GDHP to look forward in, and also to see if we can join other countries, see how they do it.
Great.
Oh, it's my turn.
It is. At least according to the script.
No, it's not. But it's okay. Okay, we have to improvise. It's all you, Steve, on my board, but it's okay.
I skipped a question.
Yes.
That's why.
Proof again, people.
I know. So in terms of your participation in GDHP and the lessons that you all have been able to learn from your other colleagues, and I know you all engage in a number of EU-related activities as well. There's an e-health data space for those of you that are tracking, what's going on in European digital health-related activities. Could you give a sense of how participation in GDHP, but also some of the other either European Commission or EU-related activities have helped the Netherlands digital health journey?
Yeah, well, the world is a small place, especially with the connective opportunities we have now. So we all know what's happening on the other side of the world, and that you can learn from that. In Europe, it helps us to point out what is happening, for instance, in the US of A. So it helps us to convince other peoples and members in Europe to take it to the next level. We are also in HIMSS. I think that's also known by you. We have a large group of people who are also invested in that. So yeah, we are in Europe, the HIMSS, GDHP, and maybe some other networks that I don't know about, but my team does. Yeah, but it's important to connect all the dots, and that we do not do do things in Europe that are conflict with the things that we want to achieve with the GDHP. So we have to have the connection, and that's what we do. Yeah, so like that.
Yes, yes. According to this, now it may be your turn.
What advice do you want to provide us as the incoming chair?
Yeah, we talked a little bit about this earlier, because obviously we're trying to do our transition meetings and the like. For those of you that work internationally, you know that time zones are probably the biggest challenge in the work. Especially, we got a colleague from Australia here as well that made the trip. Thank you. That was a quick aside. But in terms of the membership engagement, keeping the energy and momentum of the GDHP is important. That's been something that we've focused on quite a bit, building those relationships. Obviously, it's been easier to do now that we're back in person and engaging with each other in real time. I would also say finding ways to converge many of the issues that the work streams have been working on as well. For those of you that want to check out more information, probably should have put this earlier in my remarks. You can go. We have a website. We have a presence, web presence. It's gdhp.health. There's some early white papers, that GDHP has produced. We're also looking at making available some more work that the work streams have done. But as I mentioned, largely it's that kind of inner, colleague sharing of our information, and the opportunity for us to better engage, across the different governments. So that's a few of the areas that I would recommend that we focus on. We also talked a little bit about keeping GDHP engaged at the world stage, and as efforts are advanced through G7 and G20, making sure that they can rely on their digital health experts. It may come to surprise, maybe no surprise to some of you, as big and little as ONC may seem, we're part of a big department, part of a big executive branch, and we're still educating folks on what we do, what impact we can have, how our mission can help them achieve their mission. And again, across, as you heard earlier, for the panel I was on earlier with the VA, IHS, even our Social Security Administration, all the different executive branch agencies that we have within the United States government have digital health needs and digital health components that are relevant to their missions. And I'm sure similar for the other governments too. And so being able to connect the work that GDHP can do with the other kind of broader domestic aspects of their bureaucracies, I think will be important to help carry forward.
Okay, nice, thanks. I remember another answer that I could have given, but I forgot about what is going to be the priority next year.
Yeah.
This is totally unstructured, but
Sure.
it's okay.
Go for it.
It's also patient engagement.
Yep.
That is what we find really important for the next upcoming 2 years, that we design policy not only with our professional minds and experience, but also from the field and also from patients. I think that's very important, that we just not deliver and throw it over the fence, as we say it in Holland, but that we really do stuff that patients and the users of system can say yes to.
Yeah, and that's a universal theme I think we would say we've experienced through GDHP, even in the various stages that member countries are in, from an adoption perspective, from an interoperability perspective, patient access or individual access, caregiver access is a common theme that we see throughout. And certainly the Netherlands has been advancing that. Do you have a sense of, I'm curious, like statistics of how many, do you have a sense of how many, the population that can access their health information? Do we know?
I'm looking at my team, but they're looking away from me, so they don't know it.
So
either.
I ask in part. I know I sprung it on you. We try to track, and another theme I would say across GDHP members is not only just investing and working on digital health because it's cool, but because it's going to have an impact on the lives of everyday citizens and residents within those countries, and getting a sense of how impactful some of these digital health interventions are going to be. So one of the things that we focused on within the US, using FHIR, using a variety of policy levers, is getting all of us as individuals access to our health information. We have our HIPAA law, which provides an access right. You all have similar laws in the EU as well. But enabling those things from a technological perspective, and then equally building out the digital literacy and education around the availability of those tools. And I'm assuming you all have kind of the digital health literacy aspect of the work that you do.
Yes, of course. And I think, like for instance, hospitals, they're good. I mean, they also sometimes have a long way to go, but I think it's very important for the more smaller healthcare workers, like GPs, and they don't have the budgets to do it all by themselves. And that's also a question that is opposed to us as a Dutch government. From how are you going to do that for us? Can you help us with that? So we don't have the answer yet, but it is an answer that we need to. It's a question we need to answer.
Yeah. And as we so patient engagement is kind of one measure that many of us are looking at. Interoperability is obviously another. Certainly, there are different standards that the members use for their infrastructure and the connectivity, but we're trying to get a sense of how do we compare to each other from a nationally kind of representative perspective. We work with our partners at OECD as well, which is a participant in GDHP, to get a sense of how we're doing. And this is still the answer to the question, even though we're coming back and forth at this point too. One of the things I think that will be an important convergence opportunity within the GDHP is to get alignment on how we're comparing the various progress measures that we're making.
Yeah. Yeah, but that will also help to take it further because people want to see results, they want to see progress. They're done with all the nice talks, but they want to see results. So yeah, I agree with you. Yeah.
Awesome. All right.
Who's going to question who?
I think we're done. I don't know. I thought I went through all the questions that we had. You know, I'd be curious if you know, how long have you been in this role now? In your role in the Dutch government?
I'm in this role for 4 years, and I think I have this subject for 2 years because it was in my how do you say that, my responsibility,
yes.
But somebody else stole it kind of from me. So when he left, I couped it again. So now it's all now it's good. But I think 2 years, something like that. Yeah. 2 years.
I only ask because you know, each of us has our own journey in terms of how we got into digital health or the reasons why or why it connects to us personally. So I'd be curious if you have you know, personal story or digital health relevance.
Yeah, it's good that you asked because I was in doubt if I was gonna share. I mean, it's not a problem, but my mother has cancer and she's had cancer for like a long time already. So she's been in and out of hospitals for I think maybe 15 years. So she also had different kinds of healthcare. And for instance, now she needed to find another GP. And in Holland, we have a trend that your own GP is leaving because you know he's going on a pension or whatever, and then the whole how do you say that, the whole GP practice is being taken over by foreign investors who put in commercial GPs. And then it's even more important that they know what is wrong with their patients. And then you need to have the digitalization, you need to have your files in order. And also for my mother, she needed to tell her story over and over again. But there's also a downside in having everything for your own access. I have a story about a colleague of mine who went into her own file and she read about this terrible disease that she might have. Nobody told her that. But she read it in her own personal digital file. So then she called the doctor and said, I'm panicking because I see this really bad disease in my file and you didn't tell me. And then this was a whole conversation. Then they investigated again. She didn't have the disease. And they took it out of her file. But it gave her so much stress, and she panicked so much, and she still doesn't have an answer why it was in her file in the first place. So if we have a digital file, I think doctors and we all need to make sure that it's correct, what is in the file, because it's not only you and the professional who sees it, but it's also me as a patient. So also how we talk about patients, how we talk about diseases, how we, write, in files is going to be way more important than before. I compare it with the little notes your doctor used to give you. If you go to the pharmacy, nobody could ever read it.
Yes.
But now it's digital and everybody can read it. So you need to be extra sure how you put it in the system and that it's correct.
Absolutely. We both have kids, which we've talked about too.
Yeah.
And so just to share back, right? Interestingly though, I will note, I'm trying to think of the specific date. So I started at our office in 2005, and then within a few short months after that, my stepfather passed away of cancer. And so both of us, just like the discussion you heard this morning, hard pressed to find somebody that hasn't been touched by cancer of some kind or another.
Really.
You know, all sorts of misdiagnoses, records not being there, et cetera. I didn't know at the time that it would have as a profound effect on me as it does now, because I can put together the context of that experience with the work that we do. But also, thankfully being, you know, relatively healthy myself, a lot of the experience that we have with the healthcare system as well is through the pediatric stages of our kids and managing their health information and being a caregiver. And I know, have one homesick today. Sorry, wife. You know, it's urgent care visits, it's all sorts of other management for that. You know, do you have similar health information management experiences with your kids as well from the digital health perspective?
Well, I have I'm fortunate that my children never had anything. So, no, I'm sorry.
Perfect,
I can't.
perfectly healthy.
Yeah. Well, you know, maybe I also, I stopped to go to the GP for a little bit because she always gave me like the nose spray and like just a pill. I was like, yeah, I have that at home, you know, I could do that myself. So I never went again. But no, with my children, it's fine. But with my mother, it's a whole different story.
Yeah.
And, you know, I could go on and on about that. But yeah, it comes down to the same thing though.
Yes.
Yeah, to have the information well documented, that you can read it, that you can see it, and that it's available for those people who need it.
Yeah.
So, hey, there we are.
I think there's probably a comparative study in terms of the diets among children in the US and the Netherlands.
That could be. That could be.
All right, enjoyed. Thank you so much.
Yes, thank you.
We are, I think, good for time in terms of questions. So if you're curious about what's going on in the Netherlands, or curious about how we all work together as government colleagues, happy to entertain some questions. And I guess I'll do the emceeing. You can hop up to one of the mics, and we've got one here on the side. It's you.
Yeah. I'm Erik Langhoff. I'm the CMO of the Bronx Rio. And at the last meeting we had, which was, I think, January 2020, before COVID, several sessions talked about the inaccurate medical records, that about 20% were probably incorrect, duplicative, et cetera, et cetera. And I think this was also the experience in Europe to some extent, but maybe a little bit less because there's the social security numbers are more robust in Europe than here. How are we doing now, almost 4 years later?
Whew.
I'm glad you said that out loud.
Yeah. No, because I recognized something else from the whole COVID situation, and that was that hospitals weren't able, or maybe even not willing, to share their free beds, and how many patients they could help, because everybody was keeping the data to themselves. And my own minister, who was then on the board of a large hospital in the Netherlands, he made sure that there came a system so that they had to open up their data. But that was something that is something that we still work from. Mm-hmm. Like, hey, hospitals, you didn't share that data from yourselves, out of yourselves, so we need to push it a little bit. But to personal documents, I didn't hear any problems on that. It doesn't mean it's not there or it wasn't there, but it didn't come to me or us that was the biggest problem during COVID.
Yeah. And I mean, also your question, I think you heard this morning on the QHIN panel as well. In some cases, greater connectivity was a first step and a priority for a lot of us. And the recognition that there would need to be changes to data quality or a greater focus on data quality was something that people expected as well. And so I think we've reached that point. So there's a part where we can be satisfied and glad that we have reached a level of connectivity that creates issues for us from a data quality perspective. Not to say looking at the good and the future challenges ahead of us. Also, as Abigail mentioned, all of us being able to play a more active role in our care and look at our health information. I think we all have colleagues who have had stray, ghost, copy-pasted related information in records, some of which have not been inexplicably resulting. My mom had a scenario where it was a paper chart still in one of the practices, and same name, same birthday, and they just filed it together. And in that case, they could peel away the pieces of paper and refile them in a different space. I think, as many of you know, when the electronic records get merged together, that creates a little bit more of a hair-pulling situation for the clinical informaticists out there. And I think, again, greater access to our information is going to provide us with a role to play.
Yeah, we have another question.
Yeah, we have a couple.
Yeah. Oh, I don't see.
We'll work this way if that's cool. So to the middle.
Thank you so much. I'm Carol Robinson, Medauto Health and Cedar Bridge Group. My question is from a different angle. The European Union has done a lot with GDPR in terms of consumer data privacy and really worked to advance that. What do you see on the front of health data privacy across the EU?
How do you mean what I see? Because it's
Policies, laws, new
Any forecasts or
applications,
I'm sorry?
expectations?
patient
Yeah.
control
yeah,
over
yeah.
their data privacy for their health data.
Yes.
Yeah, thank you.
Well, it is a very important topic for us, and we, for instance, have, no, that's something else I was going to say. It's a very important topic to us, and we are very much engaged as a Dutch government to ensure privacy. But I'm also an advocate to tell the true story. And what I mean by that is nothing is 100% safe. Even if you have everything on paper, it's not 100% safe. So I always tell, yes, safety and privacy is really important, and we will do everything in our power as a Dutch government to make sure that people and also organizations and companies are complying to the rules that we set, but that's never a guarantee that nothing is going to happen. And I think it's important to also tell that story because that's just the truth.
Thanks. We'll go over here.
Carl Johnson from the Center of Observational and Real-World Evidence at Merck. Abigail, goede dag, welcome. And that's about all my Duolingo level 1 will let me do with Nederlands. But my question is actually for both you and Steve. And for you, Abigail, the recent EU Artificial Intelligence Act, and for you, Steve, the White House Executive Order on Artificial Intelligence. How do you see those two recent acts and orders impacting the work you're going to be doing?
Yeah.
Bedankt.
Graag gedaan. I think it's an important step that the European Union has spoken out on this particular topic. I think it is also something that is going to help us in proceeding more on this topic. And especially because in Holland the conversation is going about privacy, about what you can share, what not, and how AI is going to be used. And I think it's a really good that the European Union has set out some boundaries. I think that they're even a bit more progressive than what our own Dutch government was thinking. So that is a pro, I think. And I think it's good that within the European Union, we all have the same boundaries on what we can do and what we cannot do. From my own personal perspective, I think it's a good idea to check how those rules are going in practice. Because I don't know if you know the movie Humans. It's not a movie, but on YouTube you can find it. I don't have any shares in it, and it's also 9 years old, but it's still relevant. It's called a little movie. It's called Humans Need Not Apply. And it's really interesting even now, although we have gone further. But it's interesting to watch that little movie because it lets you see that the things you think you know now are not appropriate for 4 years later. So you need to be on top of it to see if the rules that you thought were good at this moment in time are still good 3-4 years later, because this is evolving so fast. Even my children are making their homework with ChatGPT, and a school has nothing they can do about it. I mean, if I read it, I'm like, that you did not write that, but okay. So you need to be on top of it and how you look at it, how you going to address it. I mean, for instance, the deep fake things, it's funny during election time, but it's not so funny if it happens to you. So, how are we going to address it? So I think it's a good thing that the European Union set some boundaries, but I also think it's a good thing that we as civil servants are very alert on what is happening in the field, what is happening in the future, so that we can also address it in the European Union or in our own country to, look at it again.
I'm glad that your kids are using it for the ChatGPT for homework. Mine asked it to write songs about poop. Another societal study.
You have to start somewhere, Steve.
They were quite entertaining. AI is a pretty interesting tool. I think you saw from the even discussion this morning, broad executive branch-wide interest, in AI and making sure that government is a partner in the work that's gone on. Perfect opportunity for me to highlight that we did release a rule yesterday, it seems like forever ago, that tried to tackle some of initial stages in the space that we operate, right? And so in order to make sure that there's greater transparency available to clinicians and users of health IT that goes through our certification program. And that again is to say there's a pie chart somewhere of how much of the industry that we can affect with our regulatory authority, and how many of the certified health IT products that will go through, certainly for hospitals and for a lot of ambulatory providers where they have EHR developers that are supplying what we call predictive decision support interventions. There's going to be a new kind of era of transparency and what we call source attributes that would be available to those clinical staff to review an acronym that we refer to as FAVES, to fairness, validity, and safety in terms of a few of those out of that acronym there. But this gets to the model card or the nutrition label. I know we always talk about that as a cross-industry example. Transparency and trust is really that first area that we've taken a step on. And you can see, across, from a government perspective, there are various different levers that, can be used. We're not doing this alone. As Vicki mentioned earlier today, we have our colleagues at FDA that have responsibility for medical devices. That's a little bit different in terms of how Europe approaches electronic health records. If I'm correct, they do classify them as medical devices. And so there's slightly, kind of differences across the international spectrum. And then, as we look at non-discrimination related activities, our colleagues at the Office of Civil Rights are also working on policies for what's called Section 1557 that came out of the Affordable Care Act as well. And so you've got this spectrum in terms of both the kind of device makers and manufacturers to the clinical tools that are at the point of care, all the way to the practices and actual processes that are used to deliver care and services that could cause discrimination and other types of events from an AI perspective. And so lots more to come. This will be, as we're doing predictions perhaps for 2024, a lot more out of the work from the administration as a whole in response to the executive order too. And we've gathered another questioner, so straight ahead.
Thank you. My question is for Abigail. You mentioned that there is a framework related or similar to TEFCA in Netherlands, but it's more related with personal health records. So I was curious what are the differences between TEFCA and the personal health records based framework, and another is how much of that is aligned with the international patient summary and the exchange that is done. I understand that it is sort of reasonably mature. The process that has been sort of followed for implementation of international patient summary is more mature in Europe. So from that perspective, how it applies to that framework.
Yeah, so maybe if you want to do a little bit more MedMai, then I can do a little contrast to TEFCA. I'm glad you raised the international patient summary. We'll get back to that in just a second.
I think Herco knows more about this than me, right? So if you could go to the mic.
There you go.
And We all have our qualities in life, so.
We're going Dutch on the answer to this question.
Yeah.
So thank you. I'm in Abigail's team. So the MedMy framework is exactly like TEFCA in the fact that it sets the rules for access to personal health data instead of what TEFCA does, the rules for exchanging through the health information exchanges. And instead of a health information exchange, the personal health data is with the healthcare provider. So this is patient data. And the one that accesses this data, that pulls it towards them, is the patient. So, and we use a Fire API for this that's nationally implemented with all hospitals and all GPs. And we're working on implementing it with pharmacies and other healthcare providers. And so as a patient, you have an app or a service that you have a subscription to. It's free for use now for patients. And then you pull your data from all these different healthcare sources through the API to your service. And then in that service, you can add your own data, or you can make appointments or care planning, or, well, technically you can still use it for an AI-driven second opinion or whatever you want to do with your data. You can share it with other healthcare providers or other service providers. It started out with the question of, now that you have the right to your own data, what if you get all your data in one place? So how do you safely and securely manage that? So the MedMy framework is the set of rules, and it's also got a common agreement that they sign as a service provider, that they will manage that data or the transport of that data to the patient in a safe and secure way.
Yeah, and I guess I would add the best analog from our perspective on the TEFCA side would be the individual access services exchange purpose, which we've celebrated some initial success, associated with, as was indicated. For those of you that have been following TEFCA, 6 initial exchange purposes, riding on, the already established kind of governance policies that exist through HIPAA privacy and security rules, among other applicable laws. And so you've got treatment payment and healthcare operations, you've got individual access services, public health, and government benefits determination. And so, when you look at the compare and contrast there based on your question, the individual access services is really the one, as Herco just described, using that network scale, the power of the network to be able to enable you as an individual to not remember all the places that you have your data, and to do, the sneaker net version of going to each of those and knocking on those doors. And so that's really, there's still some work to be done to make that more seamless and improve the user experience. But the network scale from a TEFCA perspective and using the common agreement and its governing policies will really, I think, create a parallel between what the Netherlands has and what we have for individual access services. All right, last question, because we're coming up on time.
Mark Roche with EMD Digital, the U.S. subsidiary of Merck in Germany, KGaA. The question that I have is, what is the level of interoperability between different countries in the European Union? Can you, for example, what happens if a Parisian person comes to Netherlands, or a Dutch person moves to Italy? Can you access digitally records from other countries, members of the European Union? In other words, what I'm asking, do you have something similar to the US TEFCA on a European Union level?
Well, I don't think it's as large as that, but yeah, right. But yes, we do have, but I don't think every country within the EU, not yet, but a few countries we have agreements with that we can exchange the data, but not with every country. So we still have some levels to go. So we're not there yet.
I would sneak in, since I raised it earlier in the prior question too. One of the other areas that the GDHP has been helping to promote has been the International Patient Summary. And so, that's been something that has been a common thread for large-scale sporting events, large-scale religious events, other types of gatherings that require a lot of international related experiences. Those types of use cases where you want to have your health information available to you or to the international clinicians in the event that you need care. That's been something that's been advanced through fire-related work, so many thanks to all of our SDO colleagues out there at the terminology level as well, within the content exchange standards. It's something that's taking shape, and different members across GDHP are using it in different ways. Some of them are using the International Patient Summary as a basis for a domestic summary that they're further expanding and constraining for their specific needs. But keeping that in mind in terms of cross-border exchange, we see that across a few of the different European members as well. Certainly there's some work going on in the US, in Canada. New Zealand was one of the more recent demos too, Australia. So lots of effort that we're starting to see. And I think John's probably out here somewhere. I forgot the URL. Is it ips.health? All right, there you go. So if you want to check out more information on the International Patient Summary and engage with the project teams there, definitely check out that website as well. So thank you so much for coming.
You're welcome.
And taking over. I don't have an actual baton to pass or a torch to pass, but consider this. We thought it would be an excellent opportunity, given the timing of the annual meeting, to bring our vice chair here, to have a transition, to have an opportunity to engage with all of you, and hopefully you learned a little bit about the Netherlands and their digital health environment. I could let you do the tourism pitch if you'd like to as well. Straight flight, direct flight from Dulles if you're in the DC area.
True. And our airport works faster than Dallas, I can assure you that.
There are nicknames for Schiphol, so.
Really.
All right, very good. Thank you all for attending. No, it's the end of the day. Appreciate your engagement. Thanks.
All right.